sometimes with pictures, certainly not with words, often detached from the event, right? If my client goes into a social situation or, let's say, a medical appointment, and suddenly, hello, everybody. I'm so happy to be here. Thank you, Rebecca, for getting us situated with all the things we need to participate. So, I am going to go straight into our material today because we are covering a lot in these 2 days. And I want to get started. So, this is a seminar that I originally called Working with the Neurobiological Legacy of Trauma because I wanted to help trauma therapists really get familiar and comfortable with how we integrate what we now know about the brain and the body's role in trauma into your day-to-day practice. So that's what we're going to do today. But let's first decide what we're going to call trauma. Because nowadays, trauma is a word that's used for a wide variety of experiences, from sexual assault to emotional coldness. And so we want to be specific about what do we actually mean. This is the definition of Karen Sackvitney, one of the early experts in the trauma field. She says, psychological trauma is a unique individual experience. It could be the experience of one event, a series of events, or a set of enduring conditions. That's very, very important because trauma treatment has been so event-centered, while in fact, most of our clients have suffered from enduring conditions of trauma. Just think, child abuse, that's not just one event. It's a traumatic environment. It's a set of conditions in which the child is never safe. War is enduring conditions. Domestic violence, enduring conditions. We could go on and on. But if you think about what brings most clients to therapy, it's one of these enduring conditions. Sometimes we might get a client who's had a single car accident or a single assault or mugging. But the vast majority of our clients come from traumatic environments or conditions. And then, in addition, the event or the conditions have to overwhelm the ability or capacity of the individual to understand what's happening now, to integrate it, to tolerate it. And very, very importantly, there is a subjective sense of threat to life, threat to bodily integrity, or threat to sanity. And that's very, very important. Trauma involves fear. It involves threat. Now, it's also relative because children are so vulnerable, especially infants and small children, that events or conditions can be traumatic for them that might not be to a 30-year-old adult. So we know from the attachment research that parents who are frightened or frightening cause the same effects on their children as abuse. We know from the work of Bruce Perry that neglect, and I don't mean emotional neglect, profound neglect, separation from parents or abandonment, all have very similar effects on the developing brain and child. Exposure to witnessing violence can be traumatic. There is a whole host of research that shows that being a witness to violence is traumatic, even if we're not the victim. Threatening words and behavior. Small children can't differentiate between impulsive words, and actual threats to safety. Rachel Yehuda has done beautiful research showing the secondary effects of parental PTSD, studying a group of Holocaust survivor parents and their adult children. She found that if the parent had PTSD, the adult child was statistically likely to have PTSD, even when that adult child had not experienced any trauma in their lives. Medical trauma, really overlooked. We forget that life-saving surgeries for children are traumatic, right? When we are patients in a hospital, we have a conscious awareness that we have consented to be treated painfully. But little children are often terrified by the pain and by the procedures. And then the death or loss of a parent or parent figure. Also traumatic for children, again, because of their vulnerability and dependency. So one of the things I learned early on in the early 1990s from Mary Harvey, who with Judith Herman started one of the first trauma clinics in the United States. And she used to say, don't worry if your clients don't remember what happened, because trauma survivors have symptoms instead of memories. And that was a great relief to us because often our clients didn't have much memory, but they certainly had symptoms. So we know now that traumatic events leave as their legacy all the symptoms of major depression, all the symptoms of PTSD, of course, all the symptoms of anxiety disorders. Every single one has been correlated with trauma, chronic pain, addiction and eating disorders, suicidality and self-harm. The research on suicidality and self-harm is dramatic. The vast majority of suicidal subjects and self-harming subjects have histories of trauma, and the same with addictive behavior. And I should add, borderline personality disorder. We have numerous studies looking at the very strong relationship between a diagnosis of borderline and a history of trauma. So these are the symptoms. And when I show this diagram to clients, they recognize themselves in it immediately. And often they say, I thought these were things that were wrong with me. I didn't know they had anything to do with trauma. And I say, oh, yes, just think, how did the depression help you to survive? And they answer without hesitation. They say, oh, it was like a cave. I could hide in it. It was like being under a blanket. How about the irritability? How did that help you to survive? And they say, that helps me to push people away. And I have to laugh when they say that, because we've all been pushed away. We know that irritability. What about loss of interest? How did that help you survive? And they always say something along the lines of, well, then they could take everything away from me and it didn't matter anymore. Because if I cared about something, they'd destroy it. But if I didn't care, it didn't matter whether they destroyed it or not. And how about the numbing? How did that help you survive? They say, then I didn't feel so much. So they get the idea pretty quickly that their symptoms have to be understood as ingenious ways of adapting and surviving. They're really, the symptoms all take advantage of the body to be able to adapt to traumatic worlds. Oops, sorry, I'm having trouble advancing the slide here. So we have to ask, why do trauma survivors have symptoms instead of memories? It's because of the fact that we have an inherently divided brain, right? We call it the brain, but in fact, memory areas are scattered all over the brain. The prefrontal cortex remembers what we know of the chronological events, but all the other aspects of memory are held in different areas of the brain. And imagine, to remember fully, we have to activate all these different areas. Now, in the trauma world, the brain model we use is a very outmoded brain model developed by Paul MacLean, called the triune brain. Called that because MacLean has really very kindly reduced the brain to 3 parts. I can remember 3 parts of the brain. My clients can remember 3 parts of the brain. And the theory says that we all start out with our most primitive brains. That's a little baby, a newborn baby, has access to basic functions, and that's all we care about in those first few weeks of life. Does the heart work? Do the lungs work? Are all the reflexes intact? The reptilian brain controls those basic functions that we need to keep us alive. And it's also where our instinctive reactions are located. But of course, the reptilian brain doesn't speak in words. It speaks in impulses. It speaks in changes in autonomic arousal, from calm to panicked. Then, about 3 months of age, you start to see signs that the limbic system, or mammalian brain, is starting to grow. And that's this set of many structures right in the center of our brains. That's our emotional brain, the limbic system. All of our emotional experience, memory, somatosensory memory, attachment and relational experience, all are driven by this part of the brain. You could say clients come to therapy for help with their limbic systems. And again, though, The mammalian brain does not speak in words, it speaks in emotion. And so it's left to the prefrontal cortex to put that emotion into words. But imagine you have one part of the brain trying to put into words the feelings of another part of the brain. The prefrontal cortex gives us this incredible ability to use words, to use our ability to reason, to sequence things chronologically, to put things together. It really changes the whole picture. It changes the picture for developing children, and it changes the picture for us adults too. But look what happens when we are under threat, when we're under those enduring conditions. The reptilian brain, so here are three parts of the brain. When we're under threat, that threat is perceived by the limbic system, specifically the amygdala, a tiny, tiny little structure that is the brain's smoke detector, fire alarm, and emotional memory center. So threat cues, of course, are immediately relayed to the amygdala, and the amygdala sets in motion our stress response system. And then something very important happens. The prefrontal cortex shuts down. We believe that that is because in a dangerous situation, instinct is faster than thinking about what to do. But that finding, which has been replicated many times, poses tremendous problems for our clients because it means that each time they're threatened, each time they're under stress, their thinking brains go offline. So we've long thought, what is it about trauma that makes it so hard to remember and at the same time impossible to forget? Right? What a paradox. Bessel van der Kolk started a series of brain scan experiments in 1995. And he began to see a pattern that explained this. He says, under conditions of extreme stress, there is a failure of memory processing, which results in an inability to integrate incoming input, leaving the sensory elements of the experience unintegrated and unattached. These sensory elements are then prone to return when activated by current reminders. And I always have to laugh when I read that last sentence because my clients would laugh. They would say, prone to return every minute of every day? What do you mean when activated by current reminders? How about waking up in the morning? Right, those sensory elements of the experience stored in the amygdala, which is the smoke detector and fire alarm, are very, very sensitive to being re-stimulated. So this shows something we didn't know in the 1990s. That traumatic memory is remembered primarily as body and emotional feeling states, sometimes with pictures, certainly not with words, often detached from the event. Right? If my client goes into a social situation or let's say a medical appointment and suddenly feels afraid, that fear may be interpreted as white coat syndrome. I'm scared of the doctor. But because we don't recognize a feeling as a memory. As Dan Siegel says, these implicit feeling memories do not carry with them the internal sensation that something is being recalled. We act, feel, and imagine without recognition of the influence of past experience on our present reality. Or a better way of saying it from Bruce Ecker, emotional memory converts the past into an expectation of the future and makes the worst experiences in our past persist as felt realities. So when your client gets triggered by you or by someone else, they're not reminded of the past. They're re-experiencing the past. And there's a difference because being reminded, right? I'm reminded of my mother, my grandmother, my father. That's a much more, that's higher level thinking ability. Emotional memory is gut. It's that feeling numb, that feeling panicky, the feeling heartbroken. And and it doesn't have and necessarily an event connected to it. We may know, I have a client right now, Suzanne, who is approaching the anniversaries of her parents' deaths and feeling a lot of sadness. She isn't reminded of her parents. She is reliving their last hours over and over and over again. And last night, we put our finger on it because she said, I just can't stop seeing these pictures. And I said, let's be curious. Must be something about how they died. And I said, were they in a lot of pain? And she said, no. And I said, were they able to tell you that they loved you? And were they able to thank you for caring so tenderly for them? And she said, no. And then she and I realized that the sadness that comes up at these anniversaries and these continual flashes of memory are really memory of the disappointment and hurt that her parents, even in their last days, could not tell their children, we love you. Now, implicit memories can take many different forms. So this is a little guide to help you as a therapist recognize them. Emotions that are disproportional to the stimulus. The client is furious, ashamed, mortified, is feeling dread or feeling fear. And we are very aware that the intensity of the emotion is disproportional. Think, that's probably an implicit memory. Patterns of thought can be implicit memories. Your client has ruminative thoughts, intrusive thoughts that are constantly predict threat. Also true for Suzanne. She's always feeling the other shoe is going to drop. Something is going to happen. And other clients I've had ruminative thoughts about failure. Impulses can be memories. Impulses to run, especially when when our clients run out of a social situation, run out of work, run out of your office, impulses to hurt the body, to drink or drug or to do something that relieves distress, or when they hide in the closet or under the bed. That's memory, right? We hide in the closet as children. It's rarely the choice of adults. Impulses to isolate, all kinds of somatic sensations, dizziness or the room spinning, pain can be memory, tingling or floaty feelings, brief losses of hearing or vision, all kinds of somatic symptoms. And then there are what I call attachment symptoms. Your client constantly yearns for connection, to be loved, or has a feeling of painful loneliness, and or fears or feels already abandoned. And it can be very hard sometimes to distinguish the reality from the memory. So for years, my client Annie has felt this painful loneliness, this sense that there is nobody there who sees her or appreciates her. And for years, I've been asking her to notice that painful loneliness as a feeling memory. And she's always argued, but I am alone. Now she can see, oh, the painful loneliness is the loneliness I felt as a child, all alone with all this abuse and trauma, and no one who wanted to know. She can see now that she's not alone, and that it's hard for her to take in the appreciation she gets. Yes, as a child, there was no appreciation, only punishment. Now, just to complicate things a bit more, we talk a lot about triggers and triggering, but we may not realize that that's actually a brain problem, because all based on this premise that the human brain is self-protective and prioritizes safety. So once we have been traumatized, our brains and bodies have a sensitivity to any cue surrounding a past dangerous situation. I can remember my first trauma client was a Vietnam vet who went hiking because he was feeling a bit better. He went hiking in Big Sur, California, which is all the opposite terrain of Vietnam. It's little scrub pines and lots of rocks. But as he was hiking in the mountains, the sun hit one of these little pine trees in a certain way, turning the leaves or the pine needles a shade of green that sent him into an overwhelming flashback. Just that little pine needle turning a certain shade of green was a stimulus associated with danger. So don't just look for the triggers that are obvious in your client's life. Look for those subtle triggers. Look for things like times of day, often very triggering, particular days of the week, the time of year, Annie gets triggered every August. August is a tough month for her. Look for things like colors or sounds. Even clients get triggered by their own emotions. Because remember, emotions are dangerous in an abused child's life, right? In a traumatic environment, it's not safe to have needs. It's not safe to have emotions. And when your client or my client gets triggered, the feelings and sensations and impulses, those memory states, don't convey the sense, oh, I'm remembering I was in danger then. It feels like danger now. That's the difference between implicit memory and verbal memory. In verbal memory, we're aware that we're talking about the past. Implicit memory, how can you tell? So, one of the things we now know, thanks to all this research, is that triggers are best acknowledged by referencing the traumatic past in general, but not by trying to connect each triggered reaction to a single past event. And that's in large part because, remember, under enduring conditions, there have been many, many, many similar events. And so a triggered reaction, let's say Annie had to go to the doctor. She's had a series of medical problems. She was abused by her pediatrician. So each time she goes, she feels a lot of fear. That's not a triggered reaction to a single past event. It's a triggered reaction to the situation. A doctor's office can be an unsafe place. Also, when we explore the past, looking for the trigger, the event to which to connect the trigger, we may actually increase the activation and we're going to have too much memory to process. It's much better for Annie just to reassure herself, I'm a grown up now. I'm a 69-year-old, 5'10" woman, and no doctor can abuse me the way my pediatrician did. We have to recognize that the body and the emotions are remembering the past. And it helps when clients get to the point that they can see there's nothing dangerous happening. Annie likes her doctor. And when she sees, oh, nothing dangerous has happened, my doctor has been consistently respectful and safe and has helped me, she can notice the fear as just treatment. So when we relate to triggering as just a symptom, its power is reduced. Very important. So I often say to clients, my goal for you is to be able someday to say, oh shit, I'm triggered. And I say, oh shit is very important because triggering, I'd like triggering to just be unpleasant. We can't make triggering go away, but we can learn to relate to it like, oh, I stepped in dog poop. Ugh, such an unpleasant experience. But it's not traumatic. Now, other symptoms develop hand in hand with trauma symptoms that represent what I call valiant attempts to cope or flee from the feelings. Self-injury, self-starvation as in anorexia, changes our physical and emotional state and brings relief. Suicidal thoughts or impulses or plans all combat the feeling of being trapped and helpless, right? The suicidal thought means, oh, there's an exit. High risk behavior. The client may not be conscious of why they're drawn to high risk behavior, but it gives you a wonderful hit of adrenaline, which is really, I think of it as a drug addiction to our own body chemicals. Reenactment behavior also stimulates biochemical changes and changes our state. Caretaking of others, such an issue for so many of our clients, combats a sense of worthlessness and then becomes almost an addiction in itself. And then, of course, substance abuse and addictive behavior gives clients what I call a designer solution to altering their emotional states and trauma symptoms. Now, the other thing that is profoundly affected by childhood trauma as well as adult trauma is our autonomic nervous system, which controls our emotions, our energy level, our impulses, a whole host of psychological issues are actually controlled by the autonomic nervous system. And this is how I explain it to clients. I say, you have a nervous system capable of very high activation, enough activation so you can run for miles, or you can be that little old lady who fights off her attacker with her cane. And we have a body capable of very, very low activation, as in hypothermia or a medically induced coma. And the high and low activation are really important for surviving. But hopefully, most of the time, we're not running from the wolves or in a state of hypothermia. And so our feelings fluctuate within what Dan Siegel calls the window of tolerance. That's the window within which we have the capacity to tolerate our feelings. Little children have a teeny tiny window of tolerance. There are very few feelings they can tolerate without help from grown-ups. Ideally, as we grow older, the window of tolerance expands so that as adults, we have the capacity to tolerate very intense feelings and also feelings of depression, fatigue, illness, being under the weather, not having much energy. But this capacity, this window of tolerance, only expands when we have good attachment. There's the rub. So that when we are very, very upset, or when we're tired, lonely, bored, sad, someone picks us up, dries the tears, hugs and kisses, reassures, and makes us laugh, and restores that little baby to that window of tolerance state. And just think, it's like working a muscle. The nervous system learns. You can get very upset, you can get very low, and you bounce back. Because as parents know, this cycle of, of very high activation, very low activation, soothing and regulation by the parent, restoring the child to that optimal state, that goes on many, many times a day. Not the case in a dangerous world, however. So when our clients come to us, they often come to us with a pattern of chronic high arousal symptoms because that's how they've survived. Right? That's Annie. She survived with being on constant alert. So high arousal, hyperarousal, is associated with, this is, I'm sure, very familiar to all of you, impulsivity, risk-taking, poor judgment. No matter how many times you and the client have talked about how to use good judgment in the moment, the client impulsively does something with poor judgment. That's also related to the fact that the prefrontal cortex shuts down when we're in high arousal. Sometimes clients report racing thoughts. They're hypervigilant. They are mistrustful. They don't want to sit with their back to a door or a window. Many have all kinds of fear, terror states, and post-traumatic paranoia, which is a term I made up to describe the fear of something happening that's already happened, right? The client says, I'm being stalked. Someone's out to get me. Well, that may be paranoia if you are in a safe world, but it's not paranoia if someone has been out to get you, if you have been stalked. Flashbacks, nightmares, intrusive images are all symptoms of high arousal. When I'm asked, what do you do about flashbacks? I say, help the client understand their nervous systems and help them work on bringing down the high arousal. Self-destructive and addictive behavior also are found most commonly in these high arousal. And then we have a set of clients who live in chronic parasympathetic hypoarousal because that was their safety, right? So for some, hypervigilance, action help them to survive. For others, just hunkering down, going numb, not responding, being seen and not heard. So the low arousal clients often present as depressed. They're very flat, they're very numb, they don't connect to any feeling. You ask, how do you feel? And they say, fine, which is always a word that makes me want to strangle. You know, when people say I'm okay or I'm fine, those are hard moments as therapists. In low arousal, the client has very slowed thinking and responding. It can feel like hours. You ask a question and there's a long, long, long pause. And then you might get a 2-word answer. Often the low arousal clients are preoccupied with shame and hopelessness. The high arousal clients tend to be anxious and angry. The low arousal clients depressed and ashamed. And they have no ability to say no. no ability to stand up for themselves. So they tend, a victim identity is probably not quite right. They tend to get re-victimized, taken advantage of over and over again, right? The hyper-aroused client never trusts. The hypo-aroused client always trusts. And then, of course, we have some clients who go back and forth between the two states. And when that happens, I bring out this diagram and I say, I explain about the window of tolerance, and I say, do either of these states, the high or the low, look familiar to you? And they laugh. And then they begin to tell me, oh, yeah, I'm usually up here until I kind of burn out. And then I'm down here. Or they say, oh, this low arousal state, that's me. I like it that way. But sometimes I get triggered into these states. Now, because of this phenomenon, which we didn't understand back in 1991, 92, Judith Herman rediscovered and represented a three-phase model of trauma treatment, originally designed by Pierre Janet in France. She resurrected it and began to try to convince the field that when it came to trauma, we couldn't treat it like we could treat distressing experience. Because first, we had to overcome the autonomic nervous system effects. Because this led to clients who self-harmed, who repeatedly planned and tried to execute suicide, who were in the grip of substance abuse, eating disorders, or who couldn't function because they had too low arousal. So phase one, Judith Herman says, is a phase of safety and stabilization where we have to help trauma survivors work with their dysregulation, right? We need a window of tolerance to be able to handle daily life, much less processing trauma. And so this was very important. She said, a trauma survivor can't recover if they're self-harming or suicidal or drinking themselves to blackout. So first, they need to establish bodily safety and control of the body. They have to establish a safe environment. You can't recover from trauma if you've gone from child abuse to domestic violence. And we have to help people establish emotional and autonomic stability. And then, and only then, can we come to terms with traumatic memory. And she said this because she'd experienced it. I was a postdoctoral fellow in her clinic from 1991 to 1993. And she often shared with us that when she first started seeing trauma survivors, that she immediately began to ask them what had happened and encourage them to talk about it. Because Freud's talking cure was what we had and what we were using. And then she saw that the more they talked about it, often the more unstable they became. So safety and stability first, she said, then coming to terms with traumatic memory. Chris Courtois said, remembering is not recovering. We have to help people come to terms with the traumatic past. Trying to remember all the details simply reactivates it. And then the third phase, Judith Herman believed, very important, a phase of integration and the development of an identity as someone who survived trauma. And she encouraged her clients to seek careers, whether they were jobs or whether they were volunteer work, that made meaning of what they've been through. Nowadays, we have a lot of popular treatments for trauma, a lot more than we had in 1991. We have supportive psychotherapy, which really includes both the remembering of traumatic events, but also is supportive in the sense of problem solving. Then we have what we developed in the 90s, which was a kind of psychodynamic trauma therapy, where we used a lot of psychoeducation in phase one. We taught stabilization skills, but we didn't just go right from how nice to meet you to what happened to you. In the mid to late 80s, EMDR, eye movement desensitization and reprocessing became available. Internal family systems became available in the mid 90s. And also in the late 90s, the somatic approaches to trauma, which came into the field because Bessel van der Kolk had said, the body keeps the score. We need treatments that also address the body. And so these are probably the most popular treatments around the world for trauma. I should actually, what's not on this list, it should be, is DBT and CBT. So my error, write that in, because certainly CBT treatment is particularly popular in Europe. Now, there are only a very few evidence-based treatments for trauma, because an evidence base requires a very structured method. And so EMDR is easily researched, and the research has been accumulating since the 1980s. So that its effectiveness has been supported over and over and over again. Prolonged exposure is a treatment that has very good effectiveness results, but on populations that exclude a subject with suicidality, addiction, dissociative symptoms, self-harm, psychotic symptoms, and is absolutely contraindicated for suicidal, homicidal, and psychotic clients. So most therapists say, well, if we take out clients with self-harm and suicidality, if we take away the clients who struggle with addictive issues and dissociative symptoms, if we exclude anyone who's ever been in a hospital, that wipes out most of my clients. So what we've found is that prolonged exposure, although it has good research results, because with a limited group of, of subjects. Also, it has a very high dropout rate. And, and that's something to consider when using it, is that I have a client who did prolonged exposure many years ago, and she said it was the worst experience of my life because it's so intense. Um, Internal Family Systems has one research study um, looking at the results with rheumatoid arthritis patients, and very, very good study with good results. And somatic experiencing also is supported by 2 randomized controlled studies. So there is an evidence base for those models, which can be um, manualized, and so you can have a number of therapists using the very same treatment um, across many different clients. Now, the APA asks us to remind you that the material in this course today will cover new interventions and new modalities that may be outside of your training. And so it's important that you think about what I'm proposing. I try to make sure that I don't suggest anything that could potentially be a risk to clients, but in the end, it's you are the person who knows the client, and so you have to make the final decision on what you will use from what I present today. And I think by and large we like that. It's a big responsibility, but I think most of us as therapists appreciate that we have to use our own judgment no matter what we're taught. I also want to remind you that most of what you're going to hear today hasn't had the research base that you see in the evidence-based techniques. But I think we have to think long and hard about risk and reward, because there is a risk to not using some of these techniques. I will tell you which ones they are. Because talking therapy, sometimes EMDR, and prolonged exposure also require a window of tolerance that many of our clients don't have. So they may be evidence-based, but there's a risk to using them. Many therapists in the VA system have told me it breaks their heart. They're required to use prolonged exposure, but sometimes their clients can't tolerate it, and they have to sit by and see their clients getting worse. We don't have to do that. We can say, okay, this might have good research results, but I'm not willing to take the risk with my client. With any form of treatment, the most important things in assessing what will work and what will be safe with a given client is the client's affect tolerance, window of tolerance, and their ability to remain present and mindful. and we'll talk about mindfulness in a bit. Um, so the if you're oh, I know what I was trying to say here. If your client would have been ruled out as a research subject in the prolonged exposure studies, um, the potential risk compared to prolonged exposure is unknown. So I think we have to use very thoughtful, responsible forms of treatment. Be aware of what has an evidence base, but also be aware that an evidence base does not eliminate risk. That's the thing that I think can get confusing. Um, and in the end, I have to use the client's window of tolerance as my best guide to what will work. So I just wanted to make sure to mention that. A mindfulness based approach has a benefit in that it stimulates activity in the prefrontal cortex. So remember, the greatest risk to our clients is a dysregulated nervous system and a shutdown prefrontal cortex. Because if the client is in that sympathetic hyperarousal state and the prefrontal cortex is offline, the risk of impulsive behavior is very high. So that's one of the reasons that I'm going to emphasize a mindfulness-based approach. And so that's very, very important. If the client has a strong emotional response but is able to stay mindful, the client will be able to tolerate that emotional response. If there is an intense emotional response and the client doesn't have a window of tolerance and doesn't have an ability to keep the prefrontal cortex online, then something dangerous could happen. And then last but not least, remember the risk to not using these approaches. Because if you have a client who's not appropriate for prolonged exposure or not appropriate for EMDR, using the approaches that I'm going to share with you in this course is probably the safest thing to do. And you can be a very careful and thoughtful and ethical judge of whether the approaches and interventions have a stabilizing or destabilizing effect. Now, the brain scientists say to stabilize, we have to help trauma clients reverse the tendency of the prefrontal cortex to be inhibited. Joseph Ledoux, who has spent his professional life studying the amygdala, says in order for the amygdala to respond to fear reactions, the prefrontal cortex has to be shut down. Treatment of pathologic fear, certainly that's PTSD, may require that the patient learn to increase activity in the prefrontal region so the amygdala is less free to express fear. Right? So crucial to get that prefrontal cortex working again. And one of the ways we can do that is to offer psychoeducation. That's why I try to share with you how I explain these ideas to clients so that you can share them with your clients. The more the client understands, the less apt the client is to decide that they are defective, worthless, and that it's all their fault. Normalize their symptoms and their feeling memories and their impulsive behavior as attempts to cope, as body memories. Label the symptoms as symptoms. So often, the client doesn't see poor judgment as a symptom. They say, I am someone who lacks judgment. The self-loathing, it's so interesting. When I say, do you know that most trauma survivors hate themselves? It's really a symptom of trauma. They're surprised. And it doesn't immediately take away the self-hate, but it begins to chip away at it. Increase the awareness of post-traumatic trigger, right? The more clients come to recognize when they're triggered, the more accurately they're going to interpret reality. And lastly, encourage curiosity. I don't say compassion out loud to the client, but I think about the importance of self-compassion. Why don't I talk about it to clients? Because if I say to most of my clients, I think we have to work on self-compassion. Compassion? I thought you understood me. How could you ask for such a thing? They have a strong negative reaction. I think because compassion is associated with vulnerability. And vulnerability is something that trauma clients become phobic of. As Judy Herman writes, the therapist's role is both intellectual and relational, fostering both insight and empathic connection. Gardner notes, he was one of the earliest PTSD experts, that the central part of the therapy should always be to enlighten the patient as to the nature and meaning of his symptoms, but at the same time, the attitude of the physician in treating these cases is that of a protecting parent. He must help the client to reclaim his grip on the outer world. And that's what psychoeducation does. It helps our clients reclaim their grip on the outer world. And then we have to help our clients become more mindful. I often say, I notice that you draw a lot of conclusions, most of them unfavorable to yourself. And they laugh because they know it's true. Mindfulness is important in processing anything. As Dan Siegel says, where attention goes, neural firing goes. And where neurons fire, new connections can be made. So how do we go from talking therapy to mindfulness? That's really something we have to lead. And how do we do that? By becoming more mindful ourselves. So I slow the pace of the conversation. I start to be more curious and observant myself, right? Because slowing down immediately begins to put any of us in a more mindful state? If I ask the client to observe without drawing conclusions, that's a new way of observing. Most clients don't mind it. And I want to help the client focus on the thoughts that come up, the feelings that come up, and the physical sensations that come up. In mindfulness, we're focusing on the present moment, not the past, not I was feeling, but in this moment I am feeling. So the technique when the client comes in talking about the past is retrospective mindfulness. The client says, yesterday was a nightmare, this happened, that happened. And I say, as you're talking about what happened, what's happening inside you now? And notice I don't ask, how are you feeling now? Because thinking, nobody told me this, is a thinking question. So if I say, how did you feel? That's a thinking question. I don't know. How did I feel? But if I say, notice what feelings come up, notice what happens inside, that's a mindfulness question. So mindfulness is present moment, and it doesn't judge, it just notices. Very, very important for clients who have a lot of shame. So this is the language, right? Notice. Be curious. Let's just notice that reaction you're having as we talk about your boyfriend. If there's a crisis, notice the sequence. Let's rewind the tape back to before something happened. Right? Where were you? Oh, you were home. You were alone. Okay. And see yourself. Are you in the kitchen? Are you in the living room? Where are you? Right. And as you see yourself at the kitchen table, notice what feelings are coming up. Right? Just following the sequence. And then what happens next? Let's be curious about what triggered you. Right? Let's go back and retrace your steps. And this time we'll be curious. You didn't know to be curious, but we can be curious now. So the words of mindfulness are notice, right? Curiosity. And there is what one of my clients called a tone of awe and wonder. I said to her one day, I said, be curious. And she said, I don't like that word. And I said, wow, what word would you prefer? And she said, awe and wonder. That's how you sound, right? Awe and wonder. And that taught me a valuable lesson, because we can't just be curious in the intellectual sense. We have to exude awe and wonder and curiosity from every pore. I have to notice if I want the client to notice, rather than interpreting, concluding, and analyzing. But it's actually, I think, in my feeling about mindfulness, is that it makes the job of the therapist much easier. And it also positively affects the client's relationship to themselves. The simplest mindfulness technique is to differentiate thoughts, feelings, and body or physical sensations. So When the client says, I feel unsafe, um, we don't, we can't conclude from that statement that the client has an impulse, because it could be that that those words are reflecting a cognition, right? A belief that the client is never safe or the world is never safe. Unsafe could mean an emotion, like I'm feeling anxious or frightened. It could be a body sensation, right? My chest is tense, my heart is racing. And so, or it could mean an impulse. So when the client says, I feel unsafe, I say, is that a thought, a feeling, or a physical reaction? And I can do that with anything. If the client says, I feel suicidal, I can say, is that a thought, a feeling, or an impulse? And I don't have to be worried about it if it's just a thought or just an emotion. So, in the early days of the trauma treatment world, it was easy to answer the question, on what should we focus? And the answer was, we should focus on the traumatic events. But that's not why traumatized clients come to us. They don't come because they want to tell their stories. I mean, I've been in practice for 42 years, and a tiny, tiny, maybe 5% of all the traumatized clients I've seen have come wanting to tell their stories. Most have come because they've been triggered, and they're starting to feel anxiety, they're starting to have flashbacks, their emotions have been overwhelming, they've been depressed, they just want to die. And the first goal when they come to us is to help them recognize that they've been triggered. Because when they don't know about triggering, when they don't recognize it, they blame themselves or they blame those around them. I'm reminded here of an old client of mine. I'll call her, what do I call her? I'll call her Amanda, who I first saw as an 18-year-old runaway in 1991, I think it was. And recently, she found me and contacted me because she was having trouble. It turned out she now has a 15-year-old daughter, and her 15-year-old daughter is very triggering. And so she has been in the grip of intense triggering, at times angry at her daughter for making her feel all these things, not knowing she was triggered. She just thought that her daughter was trying to make her feel bad, was trying to manipulate. And so at times she would blame her daughter, at times she would blame herself. So the first thing I had to do was to help her recognize that she was getting triggered. And although it takes a lot of practice to consistently recognize when we're triggered, it has an amazing effect, because immediately the individual feels less crazy. And that's worth a lot, right? To realize, I'm just triggered. It's not a desperate situation. I'm not losing my mind. I'm not a bad mother. I'm not a bad human being. I'm just triggered. So here's an example. This is a client who's actually hospitalized, was hospitalized at this time. I hear from the nurses as I was doing a consultation and program for this hospital at coming once a month to see their most difficult high risk clients. And so the nurses tell me very disapprovingly that she cut the night before. So I say, as cheerfully as I can, I say, wow, I hear you cut last night. What might have triggered you? And why did I try to sound so positive? Because a disapproving look or a disapproving tone is triggering. And remember what happens when clients get triggered? The prefrontal cortex goes offline. So if I want to have a meaningful conversation, I have to help this client keep her prefrontal cortex online. So I am exuding a tone of curiosity. What might have triggered you? And she says, I don't know. I just hate myself. That's the answer most of the time when I say, what might have triggered you? The client says, I don't know. Don't stop at that point. That's because the prefrontal cortex is shut down. And I say, okay, well, what was going on just before you cut? And she says, my boyfriend was supposed to call me, but he didn't. I waited and waited, and he didn't call. And I say, wow, what thoughts and feelings came up when he didn't call? And she says, I was mad at myself for trusting him. That's why I hate myself. So notice, she doesn't hate herself for cutting. She hates herself for trusting. And I have to validate that. So I said, oh, so you probably couldn't tell anyone because you felt so ashamed of trusting him. And she says, yeah, I thought, what kind of fool am I for trusting him? So we go on. And I say, wow, when you had that thought, what feelings came up? And she says, I wanted to kill him and I wanted to kill me. Reminder, just two sides of the same coin, right? That's the fight response. Either turned outward, I want to kill him, or inward, I want to kill me. And I say, wow, how overwhelmed were you? That's the magic word. Because when you say, that must have been overwhelming, or how overwhelmed were you? You're saying, I get trauma. Because trauma isn't just an emotion, trauma is overwhelming sensations and emotions. And she says, I was completely overwhelmed. I couldn't stand it. And I say, oh, okay. Well, cutting triggers adrenaline, so you feel calmer. You were just trying to get control back, huh? And she says, yeah, but now I'm feeling stupid and my arm is killing me. Which is my chance to say, as casually as I can, well, do you want me to show you something else to do that will help you feel less overwhelmed? It won't work as well as cutting, but it doesn't get you into trouble. Very important disclaimer. If we try to sell DBT or other coping techniques as an alternative to cutting, we have to acknowledge they won't work as well because cutting triggers adrenaline. It's instantaneous, calm, and pain relief. Right? There's no skill that offers instant pain relief. But so very, very important not to oversell the very good techniques we have. And she says, sure, you can show me. I'd like to survive this weekend. So very important. Notice that I reframe the cutting psychoeducation. I tell the client why it works. And that gives the client an opportunity to say, but now I'm feeling stupid. This was quite alarming to the hospital administration. They said, are you sure you're not reinforcing the unsafe behavior? And I said, no, because if I say, well, cutting is re-traumatizing, it's not safe, the client would say, yeah, but it's the only thing that helps. If I say, this is why biologically it helps, the client is free to say, yeah, but look, I'm now stuck in the hospital for another month. My arm is killing me. I'm feeling really dumb. And then I say, do you want me to show you something else that might help you feel less overwhelmed? Also very important to help clients begin to notice what tells them they're triggered. Because once they start to recognize the physical and emotional symptoms of being triggered, it becomes much, much, much easier to learn to say, okay, I'm just triggered. So first I tell them a triggered emotion is going to be sudden, intense, and it won't shift. It doesn't pass. Right? So look for suddenness, duration, and intensity. The other items on this list came from clients. Right? Anxiety and fear tells me I'm triggered. Increased heart rate. All kinds of stomach symptoms. One person said, I have a pit in my stomach. Another said, my stomach is tight. Another said, my stomach is clenched. Changes in breathing. Obsessive thinking, very interesting that the client noticed obsessive thinking. One person said, my response is disproportional to the event. That's how I know I'm triggered. 0 to 60 reactions. And I love this next one. This was a young woman who said, I can tell I'm triggered when I'm doing something I shouldn't do or didn't want to do. Muscle tension. Also, very good clue to being triggered. Twitches, ticking, jumping to conclusions, jumping to the worst possible case scenario, the feeling that the sky is falling. Again, these are all quotes from clients. A sense of not belonging, being on the outside looking in. Very important, because often we think of that being on the outside looking in as an emotional experience, which it can be, but it can also be a feeling memory. And then last but not least, the fear of abandonment, feeling alone, feeling very small. So that's probably not an exhaustive list, but that gives you some ideas about how to help clients tell when they're triggered. Very, very important, because it changes. I'll give you an example. I have a young client with who is married to really a lovely man, but he's quite pushy, um, and reactive to things. And so for a long time, when I first met her, she said he's domineering and he's scary. And so as time went on, I could see she's triggered by him. It's not that he's yelling and screaming and blocking her from leaving the room. It's that he's demanding in emotion, not demanding in a narcissistic way, but in kind of a needy way. And that's triggering. And so the more we began to talk about him as somebody who was triggering, the more it became possible for her to see who he really is. And now she's appreciating him. Sometimes he's still triggering for her, but she can appreciate who he is and the fact that he's actually trying to be a caring spouse. Now, I have to tell you about another kind of memory. And I promise you, we're going to take a break shortly because I realize this is a lot of material, and it may be that you already need a break, but one is coming very shortly. We have another memory system, very, very important to know about. It's called the procedural memory system, and it's our memory system for the learning of skills, habits, and also conditioned responses. But things like driving a car is procedurally learned so that you don't have to think, how do I drive this? How do I start this? Right? What makes it go? We don't have to think about that. We get in the car and drive. Playing the piano, playing the violin, playing the clarinet. All procedural learning. That's why we have to practice so much. Dance. We go to dance class to procedurally learn. Swimming. We procedurally learn different strokes. All athletic activities. Riding a bike. Right? That's why you can not ride a bike for years and get back on it, because your body still knows how to ride that bike. Social behavior. When we shake hands and make eye contact, which is our Western world social behavior, that's procedurally learned. That's why, that's why we teach kids to say please and thank you, because we want them to procedurally learn those skills. And what procedural learning does is allow us to function in the world more automatically, instead of having to think through every step, even in things we do all the time, like making the tea or coffee, making breakfast, all those very, very basic things. If you have to think about how to get to work, you haven't procedurally learned. If you could get to work in your sleep, you have procedurally learned how to get to work. Now, here's the thing about procedural learning. It's available at birth. So long before we have a brain that can remember events, we have procedurally learned responses to those events. So often clients don't remember how they procedurally learned these responses, but they're there. So trauma-related procedural memory comes up in every session. The client has difficulty making eye contact, right? Which makes perfect sense if you think that eye contact is procedurally learned in the first year of life. So if you're that little baby and you're looking around for eyes to meet yours, and you see scary eyes, you see the eyes of a sadistic parent, or a mentally ill parent, or a parent on some substance, those will be scary eyes. And what do little babies do when something is overwhelming? They look away or they close their eyes. Being able to ask for help and accept help, we learn those in the first 3 or 4 years of life. Expressing feelings in words is learned, it's procedurally learned behavior. And we get there by saying to children, use your words, honey. But our clients, coming from neglect and abuse, rarely found it safe to ask for help, rarely found it safe to accept help. And often it wasn't safe to express feelings in words. You'll see procedural learning in your clients. I call them default settings. You have some clients who automatically blame themselves for everything, or who go into shame automatically, whether things are good or bad. They go right into shame. Or we have clients who default to anger. If they're hurt, if they feel less than, they automatically, without thinking, go to anger, or shutdown, or to dissociation. Behavioral responses can be procedurally learned, right? Like impulsivity, or isolating and avoiding, or anxious help seeking can all be procedurally learned. The inability to say yes or the inability to say no, right? Some clients have the inability to say yes, some have the inability to say no. And we also procedurally learn social behavior. So you may see that some of your clients overshare. They get too close too quickly. And sometimes they're very disappointed and very hurt. Some have patterns of becoming the caretaker in every relationship. Some have a pattern of avoiding closeness or avoiding dependency. And that's my client Annie. She has this feeling of painful loneliness and yet avoids closeness. Now, it was Rachel Yehuda who said, long-lasting responses to trauma result not simply from the experience of fear and helplessness, but from how our bodies interpret those experiences. Very, very important. Right? That's the body keeps the score. So years later, the question is, what do we treat? Pat Ogden writes, while telling this story provides crucial information about the client's past and current life experience, treatment must address the here and now experience of the traumatic past. Thus, in the moment, trauma-related emotional reactions, thoughts, images, body sensations, and movements that emerge spontaneously in the therapy hour must become the focal points of exploration and change. We can't change the story, but we can change the here and now experience. That's the important point. So I'm thinking that perhaps before we go on to uh, explore more deeply the role of the body in trauma, I think our bodies need a break. Right? So here's a way to get your body moving and to um, give yourself some time to unzoom your body. Right? I don't know about you, but I find that I get a little bit stiffened having to sit in front of the screen in one position, and I need these breaks to move and to stretch. So we will take a 15-minute break, and we will come back. Let's see what time it is. It is just about um, quarter to the hour. So it's 10:43 in Central Time. And so why don't we come back at 11 Central Time, um, otherwise known as uh, 12 East Coast Time, 10 Mountain Time, and 9 Pacific Time. Okay, I'll see you back here and then we'll take some questions. Hello, everybody. Welcome back from your break. Hopefully, that gave you a chance uh, to get a snack and to use the bathroom and to move around a little bit. So, Rebecca, do we have any questions waiting for us?
Absolutely. We have plenty, Janina.
Okay.
Yes, yes, yes. So let's jump right in,
Okay.
and then you can let me know when you need me to stop so we can get back in. Okay.
Okay.
All right. So first one, when PTSD is diagnosed and then processed, then I change the diagnosis to resolved. The psychiatrist I work with said he doesn't think of mental health diagnosis as ever being resolved. Can you clarify this so I know what the protocol is, please?
Well, his opinion is certainly his opinion, but that doesn't mean it's true. It's funny. One of my clients was told by a psychiatrist recently that at her age, she should be over it. So she was hospitalized for a suicide attempt. She said, "My diagnosis is PTSD." And the psychiatrist said, "Well, at your age, you should be over it." So so I think I think that there are a multitude of opinions. Um, what I always tell people is, even though you may have resolved the trauma, you will be triggered by things in the future. There, right? I mean, we're all, whether we've had trauma or not, we can get triggered, and and it's not like your brain forgets that you had trauma. You have, you've hopefully resolved it, but that doesn't mean you're impervious to triggers. And so you can take pride in, I did all that work and I got to a very different place. But it doesn't make us trigger proof.
Mm, thank you. Next question. I have two female patients who both experienced sexual abuse from a family member as a young child. One of their current symptoms is that as adults, they cannot achieve orgasms during sexual intercourse and report not having enjoyable sex. This has led to difficulty in their romantic relationships. What treatment model should I be using to help them process their trauma?
You know, that's a very good question. I don't know. I mean, I would probably, I am not an expert sex therapist, but there are many, I would Google trauma and sex therapy in whatever area they live in and see what comes up. Um, you could also go to the website of Tammy Nelson, who's one of the most well known in that field, and see what if she has students she recommends. Um, it's not my area of expertise. It isn't that I haven't worked on it, but um, I think it's best worked on in the context of trauma. Like I would try to help my clients understand that their bodies have become guarded because it was dangerous. It was dangerous, it's like you wouldn't remember an auto accident and want to go out and drive.
Right.
Right. So I normalize it and try to help them to break it down. Like what's triggering? Like, does it feel good to be hugged or to be held? Does it feel good or bad to be touched? Is it at a certain level of arousal that they get triggered? And so I would really normalize it rather than treating it as a condition.
Thank you for that. And then another one. Do you believe that it is important to educate our clients about the sensory components in addressing trauma as we move through the therapy process?
Absolutely. Because if the preponderance of the memories are implicit, sensory, emotional, physical memories, that's very important to make clear. Many clients have said to me, I've talked about what happened for 10 or 20 years in therapy, and I haven't gotten any better. And so that's partly because talking about the details of what happened is continually reactivating it, but also because they don't understand that the main challenge is resolving the nonverbal memories. And those can and should be treated separately from the event memories. Because again, most of our clients come from traumatic environments. It's not just one event. That's part of my problem with prolonged exposure. Exposing yourself to one memory when you've had hundreds of frightening or traumatic experiences is not going to resolve a lifetime of trauma.
Absolutely. Thank you. Are we good for another one?
Oh, yeah.
Okay. All right. So, how important is it to label things as trauma? I find that some people are uncomfortable with the word and feel hesitant to saying that they experience trauma, specifically with childhood relational trauma.
Absolutely. Absolutely. That's, I remember running a trauma group and the group members saying, do you think you could change the name of the group? Because the word trauma is so triggering. And so I would encourage the therapist to ask the client what she's worried about if she calls it trauma. And because for most people, they feel that they're blaming their parents. And so we can differentiate between discussing the facts and blame. Right? If something happened, it isn't blaming to say it happened.
I like that. Thank you.
And sometimes they've been taught you're never supposed to blame your parents. That's
Mm.
the other thing. That's never your parents' fault. So
Hmm.
that could be hard too.
Absolutely. Absolutely. Different things ingrained in their minds, right?
Absolutely.
Mm. And then another one. Can suicidal ideations or even behaviors like failed attempts create the same type of trauma response? If so, do you have any suggestions on how to unpack that with the client?
You know, we're going to talk. I think we're
Mm.
going to talk about suicidality later today. And
Okay.
if not, we'll talk about it tomorrow. And
Okay.
so I can probably address that question.
Perfect. Okay. I have a client married to a woman with borderline personality disorder, and I'm working on building up his sense of identity and strength with the goal of implementing some healthy boundaries. But with the understanding that attachment symptoms and borderline personality disorder can result from trauma, is there a way to help him with this while being sensitive to her history of trauma? She refuses to seek counseling for herself. And I'm assuming they're making reference to the significant other.
Right. Right. I mean, I certainly would teach him about triggering
Mm.
and to say, when you set boundaries, it will trigger her. It doesn't mean it's wrong. It just means that she's very sensitive to boundaries. But that doesn't mean you shouldn't have them. So, so I would help him to kind of grapple with the whole picture, right? And 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 to see. I mean, it would be so much better for him not to demonize her,
Mm-hmm.
especially if he wants to be married to her.
Yes, yes, yes. That is very important. Very important.
Yeah.
And then another one. Thank you, Janina, for this fantastic presentation. I have a question regarding how to treat OCD when associated with trauma. First, how to differentiate symptoms of trauma and or OCD. For example, you mentioned implicit memories as intrusive thoughts and rumination. Second, how might you treat it differently? To give an example, I have a client who experienced sexual assault and then a university investigation that felt very invalidating. What what she struggles with today is intrusive thoughts and intense rumination when she is reminded of the investigation, overthinking what she said and having conversations in her mind where she explains and justifies herself to others to help reduce feelings of anxiety, panic, and shame. She has a history of OCD and struggles with the idea of others thinking she's a bad person.
Sounds like she's having a lot of normal trauma symptoms. And so what I would do is I'd use some psychoeducation to
Mm.
say your brain is trying to anticipate the next time you have to testify on your own behalf. Um, and it's working overtime. It's exhausting for you. Your brain doesn't know that
Mm.
it won't have. It would be highly unlikely for the same thing to happen again,
Right.
right? So that's the thing about sort of obsessiveness that's due to trauma. It's usually in the service of anticipating.
Mm.
It's like hypervigilance. And that's another way to explain it. Oh, your poor brain is being so hypervigilant. It's like it's rehearsing for the witness stand
Mm.
because it's so worried that this is going to happen again and and you're going to have to testify again.
Mm.
And I might also give her some psychoeducation about the judicial system and explain to her that in our judicial system, the whole purpose of the defense attorney is to rattle her and make her make mistakes. So it would be almost impossible for that not to happen. An adversarial justice system.
Very strong.
Now, that's not going to immediately change her self-blame, because that's obviously very entrenched, but it's at least starting to chip away at it.
Right.
So maybe we should go back to our
Yes.
to our presentation,
Absolutely.
and we will have another chance to ask questions after lunch. And Rebecca, do we have an hour or an hour and a quarter for lunch? I forgot to ask you earlier.
I believe it's an hour and a quarter for lunch, and
70
I believe we can put it in the Sid. Do you want to answer that?
70 minutes, 12:50 to 2 p.m. Central Time.
Okay. Okay. That's very specific. Thank you, Sid. Okay. Let's go forward then. So I just want to acknowledge that my training in trauma and the body comes from sensory motor psychotherapy, which is a trauma-informed somatic psychotherapy developed by Pat Ogden. And what's special about Pat is not only is she a gifted body therapist, but she also is extremely theoretically strong. And so she's used the research that has come forward from Alan Shore, Bessel van der Kolk, Dan Siegel, Steve Porges, to make sure that sensory motor psychotherapy is on a sound theoretical foundation. And what drew me to it is that it combines traditional talking therapy. So it is a trauma-informed talking therapy that includes the body. And that worked perfectly for me as a psychodynamically trained talking therapist, because I could incorporate the body without having to change the treatment frame. What's different about the sensory motor approach is the attention given to how the body has remembered the trauma. So the body becomes a source of information, but also an avenue for intervention. And I'll share with you some of those interventions as we go along. Christine Caldwell says, small gestures and changes in breathing are at times more significant than the family tree, which was a very revolutionary idea, especially for me, because when I came to study sensory motor psychotherapy, I'd been a psychodynamic therapist for almost 20 years. And at every single first visit with a client, we had done a genogram. So this idea that the genogram was less important than small gestures and changes in breathing was a really revolutionary idea. So sensory motor psychotherapy doesn't focus so much on the verbal narrative. The verbal narrative is just used to stimulate the nonverbal implicit memories, which, as we've said, is the preponderance of traumatic memory. And so it's very important to get to those implicit memories, which include the autonomic nervous system, movements, changes in posture, emotional responses, beliefs. All of those can be implicit memory. And because it's, because of procedural learning, we look for patterns, because habits of response tell us something, right? The client has too little or too much effort, is very still or constantly fidgety and moving, has a pattern of negative cognitions or particular patterns of gesture, right? Hands folded in lap versus talking with the hands. And the key is that we're observing the client moment to moment, right here, right now, and looking for how is the unresolved trauma being expressed by the body. Now, because trauma survivors are often phobic of the body, and that goes, by the way, not just for sexual abuse survivors, but for survivors of physical abuse as well. And so we have to introduce attention to the body slowly and with care. I also try to avoid the word body because I find that the word body is very triggering for many people. Arm is not triggering, leg is not triggering, neck, spine, back, chest, none of those is triggering. Feet are not triggering. But somehow the body, the word body, is. So I say, when you talk about feeling scared, how does that feel inside? Some people immediately say, I feel tight in the chest, my heart is pounding. And then I know, okay, they have somatic awareness. Great. Some people say a thought. When you talk about feeling scared, how does that feel inside? And they say, it feels frightening. And then some people might say, when I ask, when you talk about feeling scared, how does that feel inside? Some people might say, I go numb. And so we want to get a little closer in. So I could say, oh, so you feel numb. And is the numbing your whole body or just part of your body? I could say, is the numbing everywhere if I want to avoid the word body? Is there any part of you that's not numb? If the client gives me a thought, like it's not safe, I can say, okay, so there's the thought that goes with that scared feeling. What's the gut sensation that goes with the feeling of being scared? What physical sensations tell you that you're scared? Because somehow the word physical is never triggering. It's just the word body. And so I'm watching to see how dysregulating it is to start introducing attention to somatic experience. Now, one way to increase prefrontal activity is to give clients a menu of possible answers. Because remember, we ask a question, the prefrontal cortex is inhibited. The client can't answer the question. And then the client will feel stupid, will feel that they failed. So when you give a menu, it's like stimulating the prefrontal cortex. So I say to the client, when you feel the panic coming, what happens? Do you feel more tense, more jittery, or do you freeze? As you feel the anger, is it more like energy or muscle tension, or does it want to do something? And usually the answer is the anger feels like energy. And that's very important because even clients who are phobic of their anger like the feeling of energy. And then one of my favorites, right? Don't you love it when the client says, I feel nothing? But I can say, when you talk about feeling nothing, what does nothing feel like? Is it more like calm or numbing? Is it foggy or fuzzy? And then usually they can describe it. And if that's too challenging, as it may be for some clients, we can ask either or questions. Does that feeling or sensation feel good or bad? Is it more pleasurable or unpleasurable? Does it feel like something that will hurt you from the inside or the outside? I remember once my client Annie came to a session and she said, I'm really afraid. I just don't feel safe. And I said, does it feel like something will hurt you from the inside or from the outside? And she said, oh, it's coming from the inside. She said, okay, I don't have to worry about it. And then here's one of my favorites also. When you say those words, I'm a loser, does the shame get better or does it get worse? Very helpful for clients with a lot of negative cognitions to notice that when they say, I'm worthless or I'm a loser or I'm stupid, that the shame or the hopelessness gets worse, not better. So now let's talk about the effects of autonomic dysregulation, because that's really a body complication, right? We know that a traumatized nervous system doesn't behave the way a non-traumatized nervous system does. So here we are again with our window of tolerance or optimal arousal zone. Now, as the problem with trauma, as I write in my book, Transforming the Living Legacy of Trauma, is that trauma isn't over when it's over. Because due to the phenomenon of triggering, often the autonomic dysregulation gets worse over time. It doesn't spontaneously get better. So the client is triggered, interprets that as danger, which further activates sympathetic hyperarousal and tends to drive impulsivity and poor judgment. Hypervigilance gets higher and higher, and often can lead to post-traumatic paranoia, or to a kind of chronic frozen terror, like a deer in the headlights kind of frozen terror. the client tends, as the hyperarousal gets worse, there's an increase in the flashbacks, intrusive images, emotions, sensations. The speed of thoughts can go up, and self-destructive and addictive behavior become the only ways to regulate the high arousal. Or the interpretations of danger trigger disconnection and numbing, and or clients interpret their disconnection and numbing as evidence to support their case against themselves. So sad. And the defensive responses, just the simple ability to say no, the quote unquote simple ability to set a boundary, is disabled by the shame, by the low energy and tendency to collapse, and by the repeated victimization. And of course, remember, if your client is in hyperarousal or hypoarousal, the prefrontal cortex is inhibited. That is so important to remember. And I call this the post-traumatic roller coaster ride. And this was an idea I had back in I would say the late 90s or mid to late 90s, when I had probably 4 or 5 suicidal trauma clients. And at the time, some of you may be old enough to remember the days when we carried beepers. I developed a startle response to my beeper because so often it was going off because clients were calling to tell me they were about to kill themselves or they had taken an overdose. And I felt like I was on a roller coaster ride. So this tells you a lot about how my brain works. So I was trying to figure out, how did the client and I get on this crazy roller coaster ride? And I thought, well, it starts with the survivor being triggered and not knowing they're triggered, right? So the client is triggered, becomes overwhelmed, becomes uncomfortable, becomes impulsive or reactive. And the natural reaction that I think most of us have is to avoid that which is triggering, right? It's a natural reaction. The problem is that as the client isolates to avoid potential triggers, the isolation impairs what's called stimulus discrimination, which is the ability to differentiate a real threat from a reminder of a past threat. So because the isolation messes with stimulus discrimination, the client starts to get triggered more. I've had clients who isolated themselves to one room, and then everything in that room became triggering. So there's an even more strenuous attempt to avoid all triggers, which leads to more symptoms, often more severe symptoms. And finally, the client usually discovers by accident some kind of compulsive behavior or substance that brings relief. And it's usually such an incredibly euphoric experience. Like, oh, if I just smoke a joint, if I just have some beer, if I just go online shopping, I feel miraculously better. But unfortunately, whatever the drug of choice, if it's online shopping, it has a drug effect, right? I'm going to guess that with something like addiction to online shopping, we're stimulating a little hit of adrenaline and lots of endorphins. Whether it's cutting, whether it's an actual substance, all compulsive behaviors have a drug effect that lasts a certain amount of time, and then it wears off, causing rebound symptoms and the tendency to do more, right? More self-injury, more rigorous anorexic restricting, harder drugs or more drugs to replace the substances. The client will say they don't work anymore. But in fact, what's happening is the client's developing intolerance. And often, as the client desperately tries to find what will give that blessed relief, suicide planning, suicidal ideation become another go-to. And finally, the problem becomes that the survivor is not afraid of death, is not afraid of blacking out and having an auto accident. We're worried about those things. The survivor is afraid of the feelings. And so anything feels preferable, even death, to feeling those feelings. And so that's the situation in which we often find the client. Sometimes the suicidality is passive suicidality. Sometimes it's more active. But the key thing to remember is that all of these different ways of getting relief we begin to develop tolerance for, and then we need something more risky, more substances, more self-injury, more binging and purging. So in this model, the addictive and unsafe behaviors are not pleasure-seeking, they're survival strategies that help clients to self-soothe and self-regulate, to decrease the hyperarousal symptoms, to combat helplessness by increasing hypervigilance, or to combat hypervigilance by inducing relaxation, to treat the hypoarousal symptoms of depression, shame, and numbing, and as a way to function and to feel safer in the world. And here are some quotes that will help you understand this kind of unsafe behavior. Jan was a woman in her 50s, recalling the abuse she suffered when she was 5. She says, every day I would say to myself, I can die tomorrow. I got through each day by promising myself I could die the next day. So dying became the reward. If you get through today, you can die tomorrow. Annie recalled how cutting used to help her to function. She said, At 4 o'clock every afternoon, I would get really nervous, really scared, and I'd run upstairs and hide in the closet. And then time would tick by, and I'd realize it was time to make dinner. So I'd cut myself to be able to get off the floor of the closet and go downstairs and make dinner. Anita was hospitalized at age 13 for a quote unquote psychotic episode. I'm going to guess that it was probably memories bubbling up. But it was very frightening. Imagine being 13 on a psychiatric unit of adults of all diagnoses in their 40s and 50s. And she said, after I got out, or she said, while I was in the hospital, I vowed I would never, ever, ever, ever let myself go back into a place like this. And after she got out, she says, I went to a party and had my first beer. And I thought, if I only have beer, maybe I won't have to go there again. And the beer helped her through her high school years, allowed her to apply to colleges by herself, paying the application fees with a job she got. No help, no support from family, but with support from beer. And then she got through college by using beer to medicate herself. And by the time I met her, when she was 26 or 7, she was a full-blown alcoholic. Peter said, I survived as a kid by locking myself in my room and eating and masturbating until I got numb. Now, as a man in his 50s, he was an alcoholic, a sex addict, and a food addict. So when we have clients who are abusing substances to get that relief, we want to look at what they're taking and for what purpose. Because when they get sober, these are the issues that will come up again. So is the client treating hyperarousal symptoms? So I start this conversation by asking, what were your substances of choice? What did you do first? And then what did you add later? Very, very important. So the alcohol and marijuana bring down the hyperarousal. They induce relaxation. And then I found many of my alcoholic clients were then using uppers like cocaine or speed to counteract the relaxation effects, because they would get more and more and more relaxed, and then they begin to feel anxious that they weren't vigilant enough. Hypoarousal. Some trauma survivors use uppers to counteract the hypoarousal, but many trauma survivors like that hypoarousal, and they smoke pot or take cannabis in its various forms, help them to maintain a steady state of hypoarousal through the day. And that's a very common pattern, is a client who has profound hypoarousal using cannabis on a regular daily basis. Now, there are more addictive disorders than simply substance abuse disorders. Eating disorders. Remember, restricting food, or you probably may not know, when we restrict food, when we undereat, it induces a numbing effect, right? So feelings and sensations are numb, and we get a burst of energy from ketosis. So very, very important. This is, I think, a reason why anorexia is so popular, because the numbing effect over distressing emotions, coupled with all of the energy, and that's what allows anorexics to go to the gym and work out for several hours, even though they've eaten next to nothing. Overeating. I call it post-Thanksgiving syndrome, right? You all know it, right? We overeat and we get numb and relaxed and kind of spacey. That's another way of altering consciousness. Bulimia, binging and purging. I have talked with countless bulimic clients, going step by step through the whole cycle, right? What were they feeling when they had the impulse to binge? And usually it's hyperarousal. And then the compulsive eating to a point that they feel uncomfortably full and they're in a very hypoaroused state. Purging gives a little increase in arousal, but that's followed by an even deeper hypoarousal. And many bulimics described binging and purging in order to sleep. Sexual addiction. It's good for both hyper and hypo arousal. The anticipation effect, the planning that goes into compulsive sexual behavior, often is very pleasurably stimulating. So it counteracts hypoarousal to be focused on, how do I get away with this? How do I find a few hours in front of the computer while my wife thinks I'm working, or while she's out? Right? What excuse do I make to be out for the evening? So the other thing about compulsive sexual behavior is that many, many, many sex addicts tell me that what an important part of it is the feeling of being wanted and the feeling of a connection without commitment. So it's a very safe way for a trauma survivor to have some attachment and connection with no commitment. And so those are all things to consider in working with sex addiction. And then self-harm, the most sort of biologically brilliant, because what happens when we harm our bodies is that we stimulate an adrenaline response. And what does an adrenaline response do? It gives us an almost immediate feeling of power and control. Time slows down. We don't feel pain. That's why often people are in a car accident, don't feel the pain as much immediately. And then when the adrenaline wears off, they feel how overwhelming it is. So the adrenaline, right, it's not only gives relief from pain, but also this feeling of power and control. And then endorphin production is also stimulated. And endorphins are our happy chemicals that give us a feeling of well being. So the state of overwhelm, the state of distress that led the client to the client's impulse to self harm, that state is transformed to a state of relief. So, again, no wonder self injury is so addictive. And the problem we face with our traumatized clients is that sobriety brings with it a host of new challenges instead of having fewer challenges. They're just different challenges. So I explain to clients that the addiction gives them a false window of tolerance. So I can say, when you restrict, it gives you a false window of tolerance. You feel great. But the problem is that when you're sober, when you're abstinent, your window of tolerance is completely missing. And so that is a problem. So sobriety or abstinence address the addictive behavior, which is important. I don't want in any way not, sound as if that's not important. But we have to be ready while we're helping people maintain their sobriety. We also have to be aware of the challenges that are going to arise. Because not only is the newly sober client, facing the risk of relapse, but also risking post-traumatic flooding. And so we've got to constantly keep in mind the relationship between the trauma, not the traumatic events, but the triggering, the autonomic nervous system responses, the overwhelming nature of the emotions, the flashbacks. And so we have to help clients look at how the addiction and the trauma interact. The research says that up to 70%, between 40 to 70% of clients in addictions treatment have histories of trauma. This is not the problem of a few. This is the problem of many. And the real issue in the addictions field has been the traumatized sober client is at the highest risk for relapse. Is what I call a frequent flyer, has to go back again and again to because the trauma keeps complicating the attempt at sobriety. And so, in truth, recovery from either the trauma or the addiction requires recovering from both. We can't separate them as much as we'd like. Why haven't we done that? Or why have treatments been so separated? Addictions is a public health issue. Trauma is a mental health issue. And also, trauma became synonymous with the event memories. And so that is a huge problem. If we were to address the implicit memories, that's not at all inconsistent with good addictions recovery. So I want to share with you the abstinence relapse cycle, which is the model of someone whose name I never wrote down. I heard her speak in 1991, I believe. It never occurred to me that I would someday be a speaker and want to reference her model. I certainly used it a lot, but I have not been able to find her name. But it's a wonderful model. So it starts by saying, okay, the client is sober. The client is abstinent, not self-harming, not binging and purging, not restricting. But the loss of the chemical support is going to have an effect. And so within somewhere between 2 days and 2 years, sober clients notice an increase in PTSD symptoms, but they don't know that they're PTSD symptoms. They notice because they're not flashbacks. They're emotional overwhelm, more irritability or reactivity, a sensitivity to triggers, and sometimes flooding with implicit memories. Not knowing that these are PTSD symptoms, they very naturally lead to an increase in addictive impulses. But again, not always obvious, because I remember my 50-year-old gentleman. I began to see the pattern. What would happen is there'd be an increase in PTSD symptoms, and then he would start to get resentful. And he'd start to say, I deserve to have a good time. All these people trying my soul. Why can't I ever get a break? And that it wasn't obvious. I mean, sometimes newly sober individuals have longings for the drug of choice, but sometimes the addictive impulses are subtle, but very important to know they're coming. And then the relapse occurs as a panicked attempt at self-regulation. It can be a substance relapse. It can be a self-harm relapse. It can be an eating disorder relapse. But all are panicked attempts at self-regulation. I don't have to panic, though, because the negative effects of the addictive behavior is going to lead to another try at sobriety. And then the cycle will start again. I remember my 50-year-old man who was an elected public official. I would bring out this diagram and he would say, "Oh no, she's bringing out the baseball." But, in retrospect, I was usually right that he was heading toward the relapse part of the cycle. And after a while, he began to see that it was useful. But at first, I had to listen to him say, "Oh, she's bringing out the baseball again. What a drag." Now, again, we want to help people see the connection between the triggering and the addictive behavior. So this is my 50-year-old elected public official who usually, when he relapsed, just disappeared from therapy for a few weeks or months. So I was thrilled that he came in to tell me he'd relapsed. And I said, I am so glad you could tell me that you used last night. What on earth triggered you? And he said, I don't know. I just hate my job. It's always, I don't know. I'm like, well, what was going on just before? Right? So don't let that, I don't know, stop you. That's just the beginning, right? And so he says, people were getting to me. They have no respect. And I say, wow, how could you tell people were getting to you? How could you tell that they had no respect? And he says, one after another, they weren't doing their jobs. I can't rely on anyone. And then I knew exactly why he was getting triggered. Not only was he the son of an incredibly physically abusive alcoholic father, when he was 14, his mother was diagnosed as having terminal cancer. As a 14-year-old boy, he nursed her through her last days of illness. His father was too busy drinking and throwing furniture to care for his wife. Right? His father wasn't doing his job. And so it was left to my client. And so immediately I knew, oh my gosh, he is so triggered by all these people not doing their jobs. But I knew him well enough to know that if I said, oh, it reminds you of your mother, he would say, what the hell does my mother have to do with it? Right? So instead I say, oh my God, that's a pretty big trigger. People who don't do their jobs and you have to carry the load? And he says, yeah, just like I have my whole life. Right? So when I named it as a trigger, he could hear me. So I go on and I say, when you got triggered, what feelings came up? And he says, I just wanted a burger and a beer. And I had to laugh because wanting a burger and a beer is not on the list of primary emotions. And I said, ooh, so the trauma trigger triggered the food trigger. And he said, yeah, fuck it, I don't have to feel this shit. And I said, well, drinking does calm the nervous system. The fats and carbohydrate in the burger calm the nervous system. You were just trying to make the feelings disappear. And he says, yeah, but now I'm feeling stupid. My head is killing me and I don't want to lose my wife. And so, again, I have to say, well, we have to figure out a way for you to know that you're triggered. People are going to be assholes sometimes. Right? Very important to be honest with our clients. Right? I used his language. Yeah, I didn't want to say people are going to be difficult. That's not the language he speaks. I said, people are going to be assholes sometimes. You don't want to relapse over them. And he says, that's for sure. They're not worth it. Again, over and over, this is just one of many, many conversations because I have to help the client see the pattern because it's going to recur, right? The next week, a month from now, it will recur. So reframing the symptoms is also a very, very important part of the treatment because reframing always asks, how might the symptom have an adaptive intent? Right? Because they do. And and it's also a way, as Diana Fosha says, of entraining the positive, helping to combat the tendency to entrain the negative, which is what happens with trauma, right? How has the anorexia been trying to help? How has the burger and the beer been trying to help? We have to know that the addiction capitalizes on body chemistry. Right. Substances obviously affect body chemistry, but other behavioral addictions do too. Um, whether it's high risk driving, which pumps adrenaline, whether it's using uppers to increase hypervigilance. So it's what Pat Ogden calls survival resources. The survival strategies the client developed to combat the inadequacy they felt, but also often just to survive the traumatic environment. And then we can also reframe relapses. Again, trauma survivors have an extremely high relapse rate. So we shouldn't be discouraged if our clients relapse. I found a way in the 90s, I figured out a way to use relapses for clinical purposes. I began to reframe them as golden opportunities. Or if my client was in a 12-step program, I would frame them as spiritual opportunities. Because the shame simply complicated the relapse. And I would say, okay, if you miss this opportunity, the relapse was a waste. So assume that this relapse was trying to send you a message. What's it saying? Is it saying you didn't have enough support? Is it saying you missed the early warning signs? Is it saying you missed seeing the trigger? Right? So we figure out what's this relapse trying to teach? Right? So in the case of Peter, my elected public official, the new learning was that the biggest trigger was people not doing their jobs, right? And so I could say, okay, very important. Just think how many relapses have been triggered by people not doing their jobs, right? This is amazing. So we reframe the relapse, which increases motivation to get and stay sober again. One of the things we haven't done well, in our field, is we haven't been good at differentiating life-threatening unsafe behavior from non-life-threatening unsafe behavior or even unsafe thoughts. Often self-harm is treated as having suicidal intent, which is actually complicates it more. So we should always inquire, how does this help? I've even found this to be true with trauma survivors who have a suicide plan. That actually, and now I was taught, if the client has a suicide plan, that means the client is actively suicidal and could die at any time. Now I know to say, oh, how long have you had this plan? And how does it help? Because what I found was that many trauma survivors have had the same plan for 10, 20, 30 years. And that the plan is reassuring. It gives them the sense that they have a parachute. And so a parachute isn't life-threatening. And then we can begin to work on, well, let's see what we have to do to make that parachute unnecessary. Again, self-injury is rarely life-threatening. It only becomes life-threatening when the client has to self-injure more and more deeply, which takes many years. Passive suicidality is also not dangerous. And I think that's the biggest mistake we make, is that we treat passive wishes to die as if they were active suicidality. I have found that if I simply validate that the wish to be dead is a common wish in the lives of traumatized individuals, that most clients relax and it doesn't become an issue in the therapy. Or when it does, we know that the client is triggered. So I'm thinking of my client who I first saw as the 18-year-old runaway, who from time to time, when she's very triggered by her 15-year-old daughter, there are times when she wishes she were dead. And so I just want to be curious, right? And I say, is that a familiar feeling? And she says, oh, yes. There's so many times in my life when I wished I was dead. And I usually ask clients, how old were you the first time you had that thought of wishing to be dead? And clients often say 10, 11, 12. And so that passive wish to die is not a danger to anyone. And it's a fantasy. And it usually is a sign that the client is in distress. Obviously, if the client is dealing with distress by wishing they were dead, it's not going to help if we treat it as active suicidality. So the measure that, I don't know if this is in the slides or not, the measure that I use when I have reason to believe there may be a higher risk. So passive suicidality is not a risk. If a client has had a suicide plan for many years without any attempts, the suicide plan is not a risk factor. Many previous attempts and attempts that were nearly lethal are the biggest indicators of danger. So that raises my index of concern if the client has a history of many suicide attempts or even one near lethal attempt. And we have to recognize that this suicidality is another way of trying to regulate unbearable feelings and impulses. Now, here are our most common mistakes, right? We fail because we're anxious, right? We feel a sense of responsibility. We fail to validate the relief that unsafe behavior gives. We may not know that there's not much pain in cutting because the adrenaline and the endorphins are pain relievers. We fail to understand the fear of relying on people and how much safer it feels to rely on a substance or an addictive behavior pattern. Most of our treatments of suicidal individuals emphasize asking for help, failing to understand the fear of asking for help. We forget that care of the body is not a priority for trauma survivors. Their bodies, in their experience, the body is just a vehicle for other people to discharge tension. Its care has never been important. It wasn't important to their parents. They didn't learn that caring for their bodies was important. We forget that the shame and secrecy that our clients have grown up with makes it hard, makes it feel unsafe to disclose. It's much more normal at the world of trauma to withhold information or even to lie. But if we validate that, of course, they learned to keep a lot of things secret, and that we get that, they're more likely to give us more information. And then lastly, and this one I recognized in myself so often over the years, becoming engaged in a struggle in which we, the therapists, are fighting in favor of safety, and the client then has to be the proponent of unsafe behavior instead of what we need to do, which is to help the client with the internal struggle. Most clients who cut, who are anorexic, who are addicted, they know that it's a problem. We don't have to tell them that. They're engaged in an internal struggle between the parts of them that want to be healthy and the parts that want that relief at any cost. So these are where we get stuck. And that's why I've learned to give information to a client, to say, well, let me tell you why this works, or at least it works for a while, right? And then I can ask, and when did it stop working? Often I use the window of tolerance diagram to help the client to begin to see, oh, yeah, right. I can see that the amount of relief I'm getting now is not anything like the amount of relief I got before. Bessel van der Kolk writes in The Body Keeps the Score. He says, we need to calm the body and activate the prefrontal cortex at the same time, which is so true. He says, effectively dealing with stress depends upon achieving a balance between activating the amygdala and activating the medial prefrontal cortex. We've heard that before. If you want to manage your emotions better, the brain gives you two options. You can learn to regulate them from the top down or from the bottom up. And so let's talk about bottom up first. Somatic resources is an idea that comes from sensory motor psychotherapy, and it refers to the whole gamut of ways in which our bodies resource us. I mean, just think right now. Our hearts are all beating. Our lungs are doing the work of breathing. Our muscles and bones are all coordinated in keeping us sitting in our seats, focused on the computer. We're taking in auditory information, visual information, intellectual information, and the body is doing all of that without our actually saying, please breathe, please, right? That's what the body's doing without our trying to do anything. So somatic resources are supports for our well-being that come from the body level. Now, let me just say that the traumatic reactions on the left are not meant to be one-to-one with the resources on the right. The traumatic reactions, the resources can be used for any of the traumatic reactions. Sighing, the best breathing resource I know. Breathing as in the usual type of breathing for relaxation that we tend to teach our clients involves being able to take a good in-breath. The problem is, for trauma survivors, the in-breath can lead to because breathing in became associated with that fear and freeze reaction. Also, some trauma survivors are triggered by the relaxation effect. So I have found sighing to be the best breathing resource. And I encourage you, try this with me. Because in sensory motor psychotherapy, we believe that the therapist should try all of the interventions that we propose to clients so that we know what they feel like. So, sighing. And sometimes I say to the client, let's sigh together. 1, 2, 3. And even if the client doesn't do it, I keep doing it because I find they're contagious. 1, 2, 3. 1, 2, 3. And usually it might take a minute or two, but I find that clients begin to copy me. The reference to Balban, that's a study that looked at the effects of sighing on a group of clients and found it very effective. Grounding. Most therapists have been taught a visual grounding technique. Look around the room and find 2 blue objects and 1 red object. But grounding in a body sense means feet on the floor. Right? Feeling this sensation of your feet on the floor. And right now, so I urge you to find your feet You might have forgotten about them as we do when we're Zooming. Right? Feeling the sensation of the toes, the heels, the ball of the foot um, against the floor, against the shoe, but feeling that contact with the ground. Very easy, actually easier than the visual grounding. Um, Lengthening the spine is a wonderful, grounding is very useful for hyper and hypoarousal. Sighing is great for either. Lengthening the spine is particularly helpful for hypoarousal. And usually you can tell that the client needs it because the client's kind of collapsed. Your depressed client, your hopeless client is kind of, well, it's never going to get better. And then I say, well, let's see what happens if you lengthen your spine from the lower back up. And I always say, don't sit up straight the way your mother told you, because that's a different action, right? If I sit up straight the way my mother told me, that's effortful. It actually feels a little, I don't want to use the word fake because but it feels unnatural. When I lengthen my spine from the very bottom of the spine up, the shoulders come up and back, but all the energy is in the lower half of my body. And so now my spine is supported. And my shoulders are supported. By the way, lengthening the spine is a wonderful resource for Zoom fatigue. I use it all the time for Zoom fatigue because it's very easy when you're on Zoom for several hours to start to collapse a little bit, right? And then when you lengthen your spine, you're getting additional support from your body. And sometimes I ask clients to lengthen the spine and feel their feet on the floor. Because that's and I'm doing it right now, and I can feel, wow, that's a good combination, right? That's actually, that's actually feeling good because we've had quite a few hours already of Zooming. Here's another one. I'm very fond of this one. The hand on the heart. And of course, I realize, left and right are um, you're seeing me in the mirror, so to speak. So this is actually my hand, my right hand on my left side on my heart. So just put your hand on your heart and relax your eyes, or you can close them if you want. And just notice the sensation of your hand. Notice the weight of your hand. The warmth of your hand. And the feeling of breathing against your hand. And notice what happens in your whole body. And what I notice is it's a warm feeling, it's a very relaxing feeling. Ooh, it's making me want to yawn. Imagine if I were in hyper arousal and I could use this to bring that arousal down. Very, very important. Wonderful, wonderful for anxiety. The client says, I feel so anxious. And I say, notice where you feel the anxiety and just bring your hand to that place. Or the client says, I feel so lonely. I feel so alone. And I say, notice where you feel that lonely feeling and just bring a hand to that place. Right? Very, very wonderful for grief, right? The client is grieving a loss, and you say, notice where you feel that grief or that heartbreak, and just bring a hand to that place. Very, very important. Movement and gesture, particularly helpful for hypoarousal, but I've used them with hyperarousal too. I remember I had a client who often, any place, anytime, he was a professional man, but he could go into flashback in a nanosecond. It was just, and he had done a lot of trauma work, so it was really mysterious. But what we found was that he would start to feel a flashback coming on, and we would stand up. And when he got his feet under him, as we do standing up, he could feel the flashback recede. Very, very, very helpful to have that jumping up. Orient, which is really the visual grounding technique. But think orienting. That's what dogs do, right? It's a part of our mammalian heritage. Right? So, I mean, we use it when we're in a new situation. Right? If you walk into a store that you're not familiar with, you walk into a hotel, you walk into an airport, and what do we all do? We pause and we look around, right? The airport, we're looking for our airline, for the check-in desk. Right? In a hotel, we're looking for reception. In a store, we're looking for what we came to get. Right? So orienting can be very, very useful, especially when clients are hyper or hypo aroused and they've they're starting to dissociate. You can feel them going away. They're starting to get very agitated. Or I remember a client saying, I don't feel safe here. I don't feel safe. And so I said, okay, let's check that out. Right? So I want you to turn all the way to the right and just notice the corner of the office. And notice, is there anything bad happening? And she said, no. Okay, well let's just move our gaze to the window area. Anything bad happening there? No. Okay. How about over there by the lamp? Right, and by that big chair. Right? How about over here by the bookcase? How about over here by the other lamp? And finally, when we had investigated was anything bad happening, she was able to say, "Oh, phew, I'm so relieved." Um, Again, the key, because this is a body oriented approach. Remember, you want to make sure that the client's head and neck do as close to a 180-degree turn as possible, because that's our mammalian heritage. When we've kind of covered the whole field, then we know if we're safe or not. And then another one, it's a wonderful resource. I use it all the time as the therapist, relaxing the shoulders. And I'd say I probably use this for myself more often than I ask clients to use it, um, because it makes a big difference. So, those are some of our somatic resources. I hope you tried them out with me, because it really helps. Well, first of all, here's why it's necessary to try them out. Because in sensory motor psychotherapy, we teach a very important concept, which I think applies to many other methods as well. We don't ask the client to do something while we stare at the client. That is not something any trauma client could experience as state. In sensory motor psychotherapy, we do it with the client. So I demonstrate sign, I demonstrate grounding, I demonstrate lengthening the spine, and then I ask the client to do it with me, so that I'm not staring at the client. I'm aware of these resources in myself. Now, how are we doing for time? Let me just check and see where we are. Ooh, we just have about 10 minutes before lunch. Or actually, we have 15 minutes before lunch. So hang on a second. I'm just going to double check something. I want to see. I want to see how far we've gotten through the day, because this is a lot of material to take you through, um, and to cover, because we're trying to certify you in 2 days, which is not, that's a tall order. Maybe this would be a good time. Why don't we take a few questions and then we'll go to lunch, because we're starting a whole new section next. So, Rebecca, if you're there, let us take a few questions. I think I did. I think because I told Rebecca we would have questions after lunch, she's probably stepped away. So let me go back. I'm going to go back to resourcing, because what we didn't get to talk about has to do with top-down resources. So again, somatic resources is working from the body up. Top-down resources include things like DBT skills, which are, I'm very fond of DBT skills. because it's probably the most systematic approach to top-down resourcing that we have. The only caveat that I will say is um, that when the prefrontal cortex is shut down, many clients will not remember that they have DBT skills, much less be able to retrieve the ones they need in that moment. So we still have to work with the triggering and regulating the autonomic nervous system. Um, so, so because without that prefrontal cortex, it's very, very hard to use the skills. I would say probably if the client has just 2 or 3 DBT skills that they like the most, it might be good to stick with those just because, again, you're working with an inhibited prefrontal cortex. And then here's another approach that I use for let's see if I can do this. Can I do this? Oh, all right. I was just looking to see whether I can use the whiteboard, but I don't think I can. But let me, whoops, come back. But I'll demonstrate with my hands. So one top-down resource that I teach for suicidal and self-harming behavior is I say, trauma recovery is like being on a tightrope. And right, because we're always on that edge between more than we can handle or less than we can handle. To stay on the tightrope, we have to just get it just right. And so if you notice, if you've ever seen a circus, tightrope walkers have safety nets. And so you need safety nets too. And I say it, and you don't, and not just one safety net. Because even in the circus, one safety net is not enough for the tightrope walker. So I say we need 3, right? And I'll draw these on a piece of paper, right? We need 1 for dealing with feelings, right? So I might say with suicidal feelings, like just wanting to be dead. And then we've got to have 1 net for suicidal impulses. And then we've got to have a 3rd net for suicidal danger. And that's very important because each of those requires different skills and resources. So if for suicidal feelings, like I just wish I were dead, it might be a whole host of things. It might include listening to music. It might include calling a friend. It might include reading a poem or something inspirational, a day at a time book, right? Whatever helps to regulate the distress. Could be the hand on the heart, relaxing the shoulders, sighing. And in these safety nets, notice we can use top down or bottom up resources. And then for impulses, unsafe impulses, we might use very different, right? So that might be, calling a warm line or a hot line. It might mean orienting. I had a client who was feeling very suicidal, who used orienting to help her stay present and grounded. So, DBT skills, calling a friend from DBT or from your 12-step program. There are a whole range of things for impulses that have to do with reducing the intensity of the impulse and making sure the client has adequate support. And then for immediate unsafe risk situations, I always encourage people, because we can't always find a friend to call. We can't always reach a therapist. So on the safety net for high risks, call your therapist, call hotline to be there. But also I always make sure to include, go to a place where there are other people. Go to a hospital, lobby. Go to a train station lobby. Probably the hospital lobby is probably the safest place to go, because most trauma survivors would never, ever, ever, ever make a suicide attempt in front of other people that might traumatize those other people. So it's a place where they are likely to be safe. Right? Call 911 could also be a resource at that for those high risk, for the high risk safety net. And that's usually very nice because it differentiates between, safe, unsafe, and very unsafe. So very, very important. Then we also get down to the nitty gritty of what people can do. And that, of course, is reassuring to them as well as to us. Okay, so we just have a couple minutes. I'm trying to think. The other top-down resource list that I use is what I call 10% solutions. So I made up this 10% solution idea back in the 90s because I kept running into clients who would say, well, that didn't help. I tried to do what you told me, but that didn't help. And I realized they're expecting that these things are going to help 80 to 100%. And so I started saying, well, did it help 10%? And they say, oh, yeah, definitely 10%. And so I started saying, there are side effects to almost everything. There are limitations to almost anything we can try. So let's just look for things that help 10% or even 5% or more. And then if you're feeling really, really bad, just do 2 or 3 of the 10% solutions. So I started asking clients, when you notice something that helps you 10%, just bring it in. Just bring it in and tell me about it. And pretty soon, each client had lists of things that helped 10%. And I remember one client who taught me that jigsaw puzzles were a great 10% solution. And then I began to see a theme. Anything that required concentration but not effortful thinking was a really good 10% solution. So jigsaw puzzles, phone solitaire, anything, crossword puzzles. Now, for me, crossword puzzles are effortful thinking, but for a lot of people, they're concentration practice. Gardening. A lot of people said working with my hands, gardening, right? Knitting, sewing, needlework. And so that was a whole other set of 10% resources. Walking. And then also spiritual resources. Prayer, meditation, reading spirituality books, Pema Chodron, Day at a Time books, things that were spiritually encouraging and supportive. So there is such a range of things we can do. And I think what I love about the 10% solution list is that, many of the things on that list might be considered distraction techniques in DBT. But somehow, because it starts with what helps you 10% or more, it feels more organic and natural. And I appreciate that. Okay, lovely people. It is time for us to let you have something to eat. And according to our wonderful engineer, Sid, we have until 2 o'clock Central Time. And I will see you guys back at exactly 2 o'clock, and we'll take some more questions. All right. Bon appetit. Enjoy. Hello, everybody. I hope you had a good lunch. And so let us get to some questions. And I think Rebecca is here to guide us through. There we go. Hi.
Yes. Hello. How are you?
I'm good.
Awesome. Awesome. Hope you had a great lunch. So yes, we can jump right into some questions here, as we do have some really, really good ones. A lot of questions were coming in regards to working with children. So I'm going to jump into some of those. Okay.
Okay.
So already so grateful for this presentation. Will you recommend how to introduce some of these concepts to younger developmental ages, say 13 to 18, who are still living in their stress-inducing and traumatizing environments? Sometimes it seems as though there is a strong resistance to attempting to distinguish body sensations, thoughts, and feelings that are going on presently, and a strong impulse to vent or stay in storytelling mode, dissociation mode, or distraction, sidetracking mode.
Right. Understandably, because I don't think that teenagers take very kindly to that request that they go inside their bodies. So I wouldn't actually go there with a teenager.
Mm.
Um, you know, what I would do with teenagers is to take the venting and to see what we could do with it, because the venting means something, and it may be the closest they can get to telling you about their home situation. Um, and I assume that the questioner has information about their home situation, whether the teenager has disclosed it or not. And so I would probably work with that information. I mean, I've worked with kids who I had where I had information about their home situation. I remember that I worked with a 6-year-old whose mother used to call me before each therapy session and say, "I just want you to know that last night her father and I got into a terrible fight. I shoved her in a room and slammed the door in her face. She could hear us throwing things at each other." And then, so the little girl would come to therapy and I'd say, "Your mom says that you guys had a very hard night last night." She'd say, "No, we didn't." And I said, "Oh, you didn't mind her throwing you in the room and slamming the door?" My mother would never do something like that. Now, I didn't think of that as evasion or avoidance. I thought of that as really as a survival skill. 6 years old, for her survival, she needs to be attached to the mother who has all the power in the family, who knows that her behavior is abusive, but can't stop it. And so I would just sort of scratch my head and say, "Wow, that your mother told me something so different. That's so interesting." "And your dad and mom never fight, right?" And she'd say, No, they never fight." And I knew that they were having terrible fights, and one would walk out and drive away, or the other one would. But it's interesting because the therapy helped her nonetheless. Because I think with kids and adolescents, it's the relationship that matters. And I think of that a lot because I'm working now with someone who I first saw at 15, living in a very unsafe home environment, engaged in sex, drugs, and rock and roll. It was, what was happening inside the home was mirrored by how dangerous it was for her outside the home. And really, we spent most of our time talking about, she would create, she came from no money as well as a lot of trauma. So she would create these really amazing sort of punk rock teenage outfits out of old clothes held together with safety pins. So we spent a lot of time talking about her designing skills, and I would admire these outfits that she somehow managed to create so she could be cool, which again, for kids in an abusive world, for teenagers, being cool is really still as important as it is for teenagers growing up in unsafe homes. So when she started unraveling after the pandemic, who did she think to call? She thought of calling me. She's now 40, so 25 years later, I was the person she called because she remembered that I believed in her. So what I would say to those of you working with teenagers, believe in them. Don't try to do sensory motor psychotherapy with them, believe in them. And, it's amazing the power of belief in children and adolescents. I can remember this dates me, I have to say. I remember I was working with these teenage boys whose favorite weekend activity was stealing car radios. That's what I mean, it dates me. Cars, there's no car radio to steal anymore. Um, and, and, but I believed in them.
Yes.
And so they did. I mean, again, different outcomes depending mostly on the home environment, but they did amazingly well because I would listen to them vent and hear about their exploits in the theft world, and then I would remind them. I'd say, you're just at the age where you get to decide who you want to be. Up until now, you've had to be whoever your family told you to be. But now you're just at this crossroads where you have a chance to be the person you were meant to be. So let's think about who you were meant to be. Because that says, kiddo, you have a future. It's not just about what's happening now. There's a future you, and you have a chance to influence that future you. So that's kind of my approach to teenagers. And it fits with what Bessel van der Kolk's research is showing, because he's showing that what tends to work best for teenagers is not talking about their trauma or even going into the body. It's doing something. It's theater, it's poetry, it's art. The means through which the traumatized teenagers actually recover and heal.
Yes.
And including those who still have very problematic home situations.
Right. Thank you.
You're welcome.
Another question. It seems as the term trauma has become a part of common language instead of only clinical. Do you notice that it is overused and or used by some of your clients to self-diagnose? Where do you draw the line clinically when a client says that something traumatized them, but that the clinician may disagree, or it simply doesn't meet the DSM criteria for PTSD? Do you base it on level of impact, on day-to-day functioning, or something else?
I love the questioner. Thank you for that question, because I am very, very perturbed by the fact that we're using the word trauma for everything. Because I was a member of the generation who fought to have trauma recognized as traumatic. In the 90s, we still had to convince people that child abuse wasn't just distressing, it was traumatizing. So now, when we use trauma, I had a traumatic day at work. When we use trauma to talk about ordinary or just stressful things, we go back to the 90s. We go back to being a world where nothing is traumatic because everything's traumatic. 90s, it was nothing's traumatic because nothing's traumatic except war. So I am very careful about how I define trauma. Trauma, and that's why I gave you all the definition of trauma, right? It has to be a series of events, or a set of circumstances in which the individual's ability to even comprehend what's happening is overwhelmed, and they experience a sense of threat to life or sanity. So, we all have bad days at work. But I have to say that other than maybe having my life threatened once by a client, I've never had a traumatic day at work. That was scary. But right, right, that was very frightening. But there's a huge difference between stressful and distressing and traumatic.
Right.
Right. So, there's a tendency now to call cold, critical parents or emotionally unavailable parents the cause of quote unquote developmental trauma. But that's not trauma. Developmental trauma, according to Bessel van der Kolk, who created the term, means abuse during our formative years, rather than having parents who are emotionally neglectful. Which is, it isn't to say that it isn't painful to have parents who are emotionally neglectful, but it's different than being traumatized.
Right. Wow.
And the biggest distinction is in the nervous system. And I learned that when I took the sensory motor trainer, because a very close friend of mine and I took it at the same time. She has a history of a lot of trauma. I don't have a history of trauma. I just have a history of dysfunctional parenting and an alcoholic family. And we could see that our nervous systems were totally different in the training, because it wasn't that, in trainings, you do practice sessions using your experience. And so I could talk about very distressing things, and my nervous system could my window of tolerance could handle it. She found that for her to talk about distressing things meant she was out of her window of tolerance, despite having tons of skills for managing. So I would say, if you're not sure, check the nervous system. And what I say to people when they say, oh, my boss was in a bad mood, it was very traumatic, I say, oh my God, did he assault you? Did he threaten you with a weapon? And they say, no, he was just in a bad mood. I say, oh, thank God, you scared me for a minute. Because I thought, when you said trauma, I was afraid that you were in danger.
How to distinguish it, and even help them to be able to distinguish it.
Right. Exactly.
Yeah, and I think a lot of it has to do with, just more education, just more exposure to trauma, whether through media and so many things. So everyone is trying to relate and connect to it, so it becomes a part of the language.
Right. And I think it also is that it feels, I think for a lot of people, it feels more legitimate. Like some, you can say that was painful, and people are like, oh, well, get over it. As opposed to say you're traumatized, people are like, oh my God, you were traumatized?
Right.
And, I understand the wish to get more validation for, I understand why it's become such a popular term.
Absolutely. Thank you for sharing that. And here's another I think was a really good one. When a child, around 11-year-old female, is violent, self-harming, harmful towards others, and has been in and out of the hospital for behaviors to stabilize, what is your first line of defense to get them on the right path?
Well, I assume that this is a child with no window of tolerance. And I think tomorrow, when we talk about traumatic attachment and dissociation, I'll be able to say more about that case.
Okay.
Because there's a way that I would work with that 11-year-old,
Mhm.
but I'm going to give you an hour's worth of material on that tomorrow.
Okay. Awesome. 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 Now, if cutting releases adrenaline, how does it contribute to calming?
Well, if you've ever had an adrenaline response, which most of us have had, it puts you in this very calm, cool, collected state. It's very strange. I remember it well from a fender bender I had years and years ago on my way to the trauma center. Um, and I can remember I saw the car coming at me, and I realized, oh my God, that car is going to hit me. And the adrenaline started pumping. So suddenly I felt very calm as opposed to, oh my God, the car's going to hit me. I felt calm, cool, collected, very focused, and very powerful. I felt like my arms on the steering wheel were like Superman arms, and my right leg was like a Superman leg, pumping the brakes so hard. I didn't know I had the physical strength to do it. But that calm, cool, collected state was very weird, but it was very adaptive. And time slowed down. So it was like it all happened in slow motion.
Okay.
And so it was obviously a much better state in which to have a car accident than if I was freaking out.
Got it. Okay. Makes total sense how cutting has that type of effect with getting them to get back to whatever they need to get back to in that moment because they're so overwhelmed
Right.
with emotion. So that totally makes sense. Thank you for sharing that. What are your thoughts about compassion focused therapy for trauma? As a compassionate mind approach that offers psychoeducation and frames self compassion as a focus of the work, and NET, narrative exposure therapy, that involves stabilization, period, and repeated detailed reprocessing of traumatic memory as a main focus of the work. Oftentimes used with people who experience multiple traumatic events and living conditions.
Well, as we will discuss very shortly when we talk about traumatic memory, NET is not a way of working with memory that I would use or recommend. Because I don't believe that the problem in trauma is the events. It's the effects of the events that we have to deal with. The events, and actually processing events doesn't with people who've had 50, 100, 200 events is not a way of working that works. And so I wouldn't use that. And the first one you said?
Compassion focused therapy?
Oh, compassion focused therapy. If you're thinking about, are you thinking about, wonder if the questioner is thinking about Paul Gilbert's work or Gabor Mate's work. But in any case, the compassion is a very triggering word for trauma survivors. I like Paul Gilbert's approach because he teaches it as a skill that everybody needs. So it's really brilliant. He doesn't ask the client to have compassion for themselves. He says, are you willing to learn a skill that will help you heal and recover? And so it bypasses the whole issue of the word compassion being triggering.
Brilliant.
Yeah, I know. And, and I think Gabor's work, if that's the work the questioner is asking about, I think Gabor, who is not a mental health professional, he's a physician, but he's done so much to increase compassion for trauma survivors and amongst trauma survivors. And I think that's a huge, huge gift.
Absolutely. Yes. I was wondering, is there a link between trauma and schizophrenia and schizoaffective disorders and paraphilia? I just started working with a forensic population, and I'm trying to understand better. Are there resources I can seek out where I can learn more about trauma and the forensic population?
Well, that I don't know because I'm not a forensic psychologist, but I can tell you that there is a lot of research now that looks at the incidence of trauma among people diagnosed schizophrenic.
Mm.
And also schizoaffective. And what they find is that the rate of trauma histories in people with those diagnoses is huge, just as it was when they started looking at the incidence of trauma in borderline clients. So I think it behooves all of us to look at psychosis in a different way. You know, the research says you can't just think the way we always thought, that schizophrenia is a terrible sort of genetic accident. It's terrible illness that gets passed genetically. Because obviously, if it were passed genetically, it wouldn't have this strong association with trauma. So, whether the trauma, what I personally believe, there's no research supporting it, but what I personally believe is that schizophrenia is an adaptation to trauma. That one of the experts, Dutch experts on trauma and schizophrenia, proposes that delusions are a way of explaining anxiety. So think of a traumatized person who's feeling memories of fear and terror and persecution keep being reactivated. To have this belief somebody is, somebody's wants to hurt me, that belief explains the anxiety. And so I think we're going to know more in a few years.
Okay, awesome. Thank you for sharing that. Someone wanted to know the connection between trauma and ADHD. How do we differentiate?
Oh, there's another of my favorite questions. ADHD is a set of symptoms. The diagnosis says nothing about cause. We do know that a certain percentage of people with ADHD or ADD have parents or grandparents with the same, kind of neurodivergence in a way. But we also know that those symptoms are very common in trauma survivors. So my own theory, as yet unproven because no one has researched it, basically what somebody would have to do, which wouldn't be that hard, is to take a group of individuals diagnosed with ADHD, interview them to see how many have trauma histories. And I think all of us would agree it probably would be a pretty high number. Right? So my thinking is that when I encounter a client with ADD or ADHD, I ask them about whether anyone else in their family had these kinds of issues. I ask them whether, I have a different approach. I don't ask for a formal trauma history.
Mm.
But in the process of getting to know them,
Mhm.
I get to know their trauma history. And so I can guess, okay, this person has no relatives with these
Mm.
symptoms. They do have a trauma history. I'm going to guess that the symptoms are caused by trauma. Also, trauma survivors with ADD are less likely to be helped by the medications.
Mm.
Whereas the biological ADD folks are more likely to be helped by the medications.
Mm.
So I think we have to find out,
Mm.
based on the results,
Mm.
if we treat someone's trauma, do the ADD symptoms get better?
Mm. Mhm.
I think the prefrontal cortex is going on and off. So you can see how that would cause loss of focus, distractibility,
Mm.
absent-mindedness, right? Or what would look like absent-mindedness.
Right. Mm. Very interesting. Thank
Yeah.
you for sharing that.
Yeah. So let's see. We probably could do one more
One
question.
more? Okay. Okay. I have done most of your trainings